A warm welcome to our new steering committee members, Jeremiah Bell. I saw him on here earlier. And Jeremiah, thank you for the personal favor you did for me. And Pete Kniesny, I think he is out of the country at this point. So, but say welcome to him next time you see him. He'll be at our next meeting. Okay, Mary.
All right, we're going to get a Granite Hills Hospital update. And I'm happy to welcome Jennifer back to the meeting to provide us with an update and we've provided some questions in advance. And Granite Hills Hospital is the new behavioral health hospital that will be providing services to individuals that receive services today from Milwaukee County Behavioral Health Division at the Mental Health Complex. So Jennifer, I will turn it over to you.
Thanks, Mary, and thanks everyone here on the committee. I really appreciate your time and being afforded the opportunity to come and give a few updates. I also want to thank everybody who was able to come and tour our facility. And Deanna Meyer, my Director of Business Development, is here on the line, and I just want to thank her for coordinating and completing those tours. I hope that everyone had an opportunity to come to one of those tours. In the event that there is an additional need, please reach out and let us know. What we wanted to do today, though, is for people who were unable to come, we wanted to share with you a brief video virtually of our virtual visit throughout our hospital. So I know that our hosts here today are going to go to our website, and if you would please join us in this quick virtual video.
All right. Jean, is it not working? I did make you a co-host.
Yeah, it's not working for me to share, so.
All right, well, I will share my screen then, just 1 minute here, folks. Again, thanks for your patience as we navigate the tech.
Thank you so much for putting that up for me. I appreciate it. I wanted to just check in with people who had an opportunity to tour and now see a little bit of the virtual visit. What did people think? I'm really interested in people's reactions. I got some comments and things that we need to follow up on, and we will do so. But I just wondered if anybody wanted to share any feedback today and today's committee.
Looks like Brian has his hand up. Brian Peter.
Yes, this is Brian Peters. There are some access issues that I've noticed. I feel that I've brought it up and I noticed that the tables in the corridor are not accessible. They don't have the knee and toe clearance.
Mm-hmm.
So every time that a table, they should have at least one for the minimum for wheelchair access.
Yeah, thank you for that. We did get that input when the tour occurred, and we are assessing our dining area. We're assessing our kitchen area. We're gonna check to see for the correct clearance, and in the event that that is not available, we will have an alternative table in order to meet requirements. So we did take the list of areas regarding access, and we do have a plan going forward. We also are in receipt that in the next month of additional outdoor furniture that will accommodate the needs of individuals who come to our setting. So we do have another furniture equipment that will be coming our way.
Okay, thank you for that.
Okay, I'm not hearing any other feedback. Obviously, we have a list of items that we collected when people toured, so we will follow up on that accordingly. So thank you so much for coming and letting us know.
Jennifer?
Yes, ma'am.
Oh, and this is Mary. I was just wondering, would you be willing to share a couple of the items that people did bring up out of curiosity?
Sure. So the items that I recall, and I don't have the list right in front of me, had to do specifically with access regarding the tables, which we just discussed. There was a question regarding access and use of the exam tables, making sure that we had an accommodation for use of a specific exam table. We had some feedback regarding kind of our ambulance bay or our Sally port. There is a fan that's there for infection control and for the indoor and outdoor area, that it was actually, it was quite loud. We did follow up and identify that we actually have a switch that we could turn on and off there. So I believe we can satisfactorily address that. We also had some questions regarding 2 beds in a particular room, and that's a question that I will get to when I respond to the questions that were submitted our way. We also had some really good clinical questions regarding who we would be serving and how we would coordinate needs of individuals who had other alcohol and drug abuse conditions. So we had some great discussion about, me bringing on the providers in order to, answer those questions thoroughly. Those are things that I had when individuals stopped by and toured with me that I can readily recall without the list in front of me. But what we did is we gathered all that information and reviewed that with some of our environmental support and regional support in order to identify some solutions. So we appreciate any and all feedback.
I guess equally, were there some things that people were really impressed with or highlighted that they really thought were excellent things that were included in the build?
Sure. Some of the pieces that I heard just from what everybody has indicated to me, there was a lot of feedback appreciating the colors and the tones of the environment, the safety features in the inpatient unit, specifically the amount of outdoor space that there was. We had some feedback regarding the kitchen area, and people excited to hear that we would be cooking, you know, on site, and that would be available for patients. We had one concern regarding that the guard, there's like a guard over a salad area or an area that is used for lack of a better word, a sneeze guard and or an infection control panel. And there was a question whether that was glass and if that could be used to harm oneself. And we checked into that, and that glass is a permeated glass that in the event it was broken, it would not pose a safety risk. It would, you know, pebble in the event that that was cracked. Other feedback I received had to do with the gym and having access to physical exercise. People really appreciated that. I think that just seeing it and having that opportunity for our patients, you know, is just a great asset or a great option we have here. I received feedback on the courtroom area and just how that was set up, and it truly is set up pretty remarkable. And so feedback there. And I got some comments too that people noticed that we are all on, you know, one floor and there's not, you know, elevators and that sort of piece. So the layout and the scheme of it and ability to access, you know, one floor, that was a positive. And I'm sure there's several of you here who may have mentioned more positive to me, but that's what I can readily recall at this time.
Okay.
Jennifer, there were a couple questions or comments about the fencing around the facility. Can you talk to why there's a fence around the facility?
Yeah. So part of, oh, I just got an invite to start my video. Let me see if it works. No, not yet. That's okay. Yeah, so there's particular fencing around the outdoor courtyard areas. The aesthetics of it were in collaboration with the city of West Allis. There's two components to that fencing that will still need to be addressed. One is the height of it. It will be raised and it will be higher. So that is one of the components we will be doing. And then we are also seeking to secure, it's a privacy type screen product that would be on the outside of that, obviously for privacy and concerns to making sure that things aren't passed through that fence that would, you know, be used to, you know, harm oneself. So that is the fencing component will be further improved upon. And that's our plan currently at this time. Did that answer your question?
I don't know if you can read the chat. It said, I think the comment was it looked dangerous with spikes. So is the fence itself a danger?
Sure. Well, it will be taller, and I would suppose for me to say that it wouldn't be dangerous, that, you know, that would be, you know, inaccurate, just for the fact that if somebody was to climb, you know, our goal would be not to have somebody to climb. So we're going to make that tall enough so that individuals couldn't access that area that is curved, that is a standard product that is used in the behavioral health settings. We'll continue to evaluate. We're hoping that extension will not allow somebody to then be able to scale that fence properly. And with the netting and the privacy screen, that would be another deterrent, being able to even move up that fence. But we will continue to monitor and evaluate. And the other component here to remember is our outdoor courtyards or indoor courtyards, these will be staff supervised areas. So there are things in place in order to manage a risk, but our staff are also there to identify if there's a concern and to monitor in time.
Thank you.
You're welcome.
Hi, this is Kim Pinch from Managed Health Services. I had an opportunity to tour last week. So just wanted to thank you again for the opportunity. We gave some feedback while we were there, so I won't rehash that. But again, I think it looks great. I think you were very mindful of a lot of things that you wanted to improve based on the feedback on prior meetings. So I'm sure, I'm sure there'll be some lessons learned and things that will come up as you go since it's new. But again, just wanted to thank you for the opportunity to tour.
Thanks, Kim. Appreciate it. Okay. Any other items in the chat that I'm missing? I'll just.
Okay. So far, positive comments about how great the colors and decor and basketball courts are.
Yeah, I see that, and I see talking about soothing colors and decor, awesome clinical and rec spaces, murals, well layout. No, I appreciate it. Thank you so much. Basketball courts. All right, I think that's everything in the chat. So thanks for, I'm kind of toggling between a couple screens here. So thanks for giving me a little time to do that. All right, I wanted to give some updates briefly regarding Granite Hills and go through the questions that the committee forwarded to me. I'm gonna start with one of them out of order because I believe it gives an update as to where we currently are with opening. So one of the questions, it's actually question number 8, but the question was, when will the hospital be fully staffed and functioning? What is the timeline for transitioning patients from the behavioral health division? And how soon do you anticipate the hospital to become Medicaid certified? So, we are working very diligently to open the hospital, including recently receiving our pharmacy license and onboarding our new staff. Opening of the hospital is dependent upon completion of our behavioral health certification, receipt of our hospital license. We're working with our state partners on that. Continuation of readying our pharmacy, ensuring all of our staff are in place, trained and ready to go. I anticipate 2 openings, and this may be a new concept for many here on site here, including a soft opening, if you will, in quotes, beginning with individuals involved with our partnership with Milwaukee County Behavioral Health Division, and then a subsequent additional opening as our capacity increases. So what we need to do is to have a unit of 10 to 12 individuals to start to open our facility and then complete all the required surveys, including Joint Commission accreditation. So our plan would be to have that initial soft opening with Milwaukee County to work with their patients who have come in a transition and phased approach. And then as we bring more staff online and when we get the appropriate approvals, we will move forward with increasing capacity. The next question that was listed here was, what will be the COVID safety protocols at Granite Hills? Will you utilize single rooms instead of double? What will be the protocol for group sessions and other congregate activities? Will there be visits with families and advocates? So our plan is that all patients will be screened for COVID-19 and additionally tested if indicated. If someone tests positive, we will accommodate that individual. We'll identify the designated unit. We will ensure our precautions are in place, which may include a single room. We will be working through a process for patient group participation to ensure safety. In like similar settings impacted due to COVID, we may have some visiting restrictions. We will work to keep everyone safe, including mask wearing, social distancing, and use of our outdoor space. The next question is, what is the rationale for having all patient rooms double, and what will be the protocol when a single room is needed? So double rooms are our standard configuration for our behavioral health settings, but if a single room is identified to be in need, an accommodation will be made. So it really is dependent upon assessing the needs of an individual and then providing the appropriate care environment. Number three, the question number three is, how will security be handled at the hospital for our behavioral health setting? If law enforcement is called to the hospital, how will you mitigate the trauma of law enforcement exposure for patients, prevent escalation that law enforcement involvement can cause, and prevent further entry into the criminal justice system for our hospital patients? So our staff here at Granite Hills will be trained in CPI, or nonviolent crisis intervention strategies, which is designed to help teach us the best practices for managing difficult situations, including using our nonverbal and verbal techniques to diffuse difficult situations. We will not have a contracted security team. Rather, we will train our clinical teams to intervene safely and accordingly. Safety on the units will also include a focus on a structured setting with programs and activities. Law enforcement will not be utilized to manage our patients, rather only contacted in rare circumstances that would warrant such an extreme intervention. So our plan is to train and equip our staff to intervene and provide safe care. Law enforcement is something that would be called in an extreme emergency, and it should be extremely rare for those particular causes. The next is, how will people be transported from the Emergency Mental Health Center to Granite Hills? I know that the Emergency Mental Health Center is something that's coming online in the future, so I can't tell you the specific transportation plans at this time. However, any individuals that are required to be transported safely to another care environment, it's based on their needs, and that setting will have to facilitate that transfer, and we at Granite Hills here will collaborate with those parties to ensure there's a safe transition of all who come to us who need care. The next question is, for uninsured people, if they are admitted at a private hospital, will they be transferred? For uninsured people, if they are admitted at a private hospital, will they be transferred to Granite Hills? So Granite Hills will be an option for all who need our care, including the insured, underinsured, and no insurance. So transportation would need to be arranged by that sending facility as to safely transport the individual here to Granite Hills. And just as indicated above, we will collaborate with those parties to ensure safe transitions of individuals. So someone may come, for example, in an ambulance, somebody may come in a supervised, arranged transportation. Whatever the need is of that individual, that sending facility is to assess and ensure that those connections are done properly. The next question is, how is the hiring process going? What positions are filled and what's ahead? And can you tell us about your leadership team and how will you coordinate with BHD, the Behavioral Health Division, on hiring? So our hiring process is going well. We still are in need of more registered nurses and physicians and cooks for our new kitchen. My leadership team is onboarding, and many of those who I've brought on board have experiences with various health systems in the community, including individuals from Milwaukee County. I'm going to continue to coordinate with Milwaukee County and those interested in coming to our setting. Several have applied with us and are on site already or scheduled to come on board. Number 7, what will be the role of certified peer specialists at Granite Hills? So my plan, and I touch base with Shirley, since we've talked, I've also talked to Mary and others. I am really interested in providing a paid employment opportunity for peer specialists at the setting, because I want the peer specialist to be a member of our team. So that's the decision I made regarding peer specialists. The duties of the position will include, but not limited to, supporting those who come to us for care by providing direct support in order to help navigate the healthcare system, accessing resources, and sharing the recovery journey. And I'm working on the details of the position and the duties with others who are informing me in the process. So I have some feedback that's been coming my way, and I just encourage everyone here to watch for our posting. Number 8 was the question regarding opening, so I'll move past that. Number 9 is what will be the transition with PCS and when is PCS closing? So I would defer to Milwaukee County Behavioral Health Division on the exact date of that, but my understanding is that PCS will remain open until the transition and occupancy within the new mental health emergency center. So I would anticipate here at Granite Hills, we would receive referrals from PCS now and from the new emergency center in the future. And I'm not sure if anybody from Milwaukee County is on and able to clarify anything to that nature. Okay. Number 10 is how will Granite Hills staff coordinate with the jail and justice system for people who are in jail or from jail? Well, we're going to work with our clinical team and specifically our director of clinical services and the coordination of resources and relationships with the jail and justice system. I anticipate requesting a liaison to come on site to educate our team. And if there's any feedback here from this group or committee who would be interested in coming to talk with us, I would certainly welcome someone to come on board in order to establish those connections at the beginning. Number 11 was describe the staff roles that will be based at the hospital to connect patients to community services and what will be the roles to provide effective and safe discharge planning and connect people with services. How will we partner with BHD, the ADRC and family care and IRIS. And again, you know, this is one of the benefits that that I'm really appreciative of with my relationships with various providers in the community. But our plan will be to schedule partners to come to our facility to work with our leads and our teams to discuss community resources and how to access these services. You know, I recognize, as I did when I work with the county, is that we need to maintain regular meetings with community partners to ensure our staff are continually informed because things change. I want to give a special thank you here to Denise Johnson, who actually will be coming and providing some additional education to our staff tomorrow. So I encourage anyone in this team and this committee who has additional knowledge and resources to share to connect with us, and we can bring people in order to help us, you know, be competent in order to do what we need to do. And they can reach out to Deanna Meyer, my Director of Business Development, directly, and we can coordinate those learning opportunities for us.
That's so great to hear, Jennifer.
Yeah.
Thank you so much for following up on that and being so responsive, and thanks to Denise. Yeah, we're excited for tomorrow. So we, just so that the team knows, so if you can imagine, we got this track of hiring people and bringing people on board. So we've had various versions of orientation, and each one we're adding and putting more information and bringing the team together. So for Denise to come on board tomorrow is really going to be spectacular for our folks. So once again, thank you. And then the final piece here had to do with what is the approach for discharge planning and how will follow-up happen with CARS, mobile, the crisis, meds to minimize the likelihood of future crises. So my response, putting my social work hat on, you know, our discharge planning in our setting, you know, occurs immediately when the patient, you know, comes to us, including identifying their support systems and providers. And throughout the stay, our clinical staff, including our social workers and the multidisciplinary team, will assess and identify, with the patient's input, of course, a plan to support their wellness in the community. We will be certain to bring our crisis service partners to ensure our team's informed of resources available to minimize the likelihood of future crisis and ensure patients who come to us for care are knowledgeable about these resources. We recognize that in order for this to work, that we can't solely focus on hospital care and services here within this facility, that we need to establish the correct connections, both prior to somebody coming and then when somebody does, when someone leaves. So I'm really excited. Part of we have a new admissions director who's on board, and she's hired parts of her team. We're going to be reaching out to our community services branch at the county, including the crisis services branch at the county.
And again, bringing them in order to share those resources to make sure that we are equipped to connect people appropriately. And it's going to have to be an ongoing partnership because, like, as I indicated before, things do change. Again, if folks have some specialty related services and want to connect and partner with us here, please reach out to Deanna, and then we can continue to build our resource complement in order to do this work well and give people afford people the options that that they have. So I talked really fast, team. I went through the 12 questions that I received. I wanted to give a brief overview of Granite Hills. I wanted to thank you all for giving us feedback and input as we continually improve here. And I'm certainly open for any additional questions, either in this format here, this group format, or one-on-one, and or to reach out to Deanna as well, to come in and meet with our team. Any other questions?
I think we have time for one more. Denise Johnson had one in the chat.
Oh, all right. Let me check it out here.
Yeah, just a quick question for you. I'm just curious about whether Granite Hills has a VRI set up already for other languages ready, that when they're admitted, so you don't have to look around for interpreting services. You have a VRI there, video relay interpreting services ready for when they're admitted?
Yes, excellent question. And thank you so much. So what I've learned here at Granite Hills and through Universal Health Services, they have a corporate agreement with a company called Globo, Globo. I don't know if people are familiar with that particular organization. They provide interpreter services on site and or via alternative methods. And we literally just activated our contract with them, and we will be meeting with them to go through their menu of services. So I could probably give you some follow-up detail on that in a subsequent meeting as we become a little bit more informed of their suite of services that they'll be able to provide us.
That would be great.
Okay.
Thanks.
Thank you, Jennifer.
I'm sorry I can't see you all. I can't be on screen, so I apologize. I don't know what happened.
Well, you'll be back with us again and you'll have another opportunity. Thank you so much.
You're very welcome. Thank you for the time and thank you for your partnership. It truly makes a difference, so I appreciate it.
Christine.
Thank you. Now for the next topic, Medicaid non-emergency medical transport, update and changes. Thank you, Nick, for joining us today. Thanks to the VAO representatives. Having reliable, accessible transportation for medical appointments is critically important for Medicaid members who live with a mental illness. We've got a lot to cover and may have limited time for questions. Please put all of them in the chat and we'll share with Nick if we don't get to all of them. Thank you.
All right, great. Can everybody see this slide presentation?
Yes.
Okay, excellent. All right. Well, thank you everybody for having us here today to talk about our non-emergency medical transportation or NEMT benefit, the transition to a new manager that's taking place starting November 1st, and some of the service enhancements and policy enhancements that we hope are going to make a difference in our members' lives. I'm going to go through some of this at a high level because you guys should have received the slides in advance of the call, and we have limited time. And I really want to focus, save time to talk about the new policies, service enhancements, and give Adam Thomas, who is the Wisconsin operations manager for our new NEMT manager, VAO, an opportunity to introduce himself and his team and talk about their operations and their new service enhancements. So I'll give you a brief overview of NEMT. I think that most folks are familiar with it. We'll talk about some of the key policies and processes related to this benefit. And then we'll talk about this transition to a new NEMT manager, VAO, and we'll talk about some of the service and policy enhancements. So I think most folks know that our non-emergency medical transportation benefit gives members, Medicaid members, and the means to get to their Medicaid covered services. Not meant to be emergency transportation. If there's, you know, in a case of emergency, dial 911 and get an ambulance to take care of you. But for routine and urgent rides, that's what NEMT is for. Medicaid, as some of you know, is heavily regulated, and NEMT is no different. We've got two regulations cited here. What they basically say is that we are required by the federal government to provide the least costly type of transit that meets the members' medical and transportation needs. So members really don't get to choose what mode of transportation that they get. Their needs are assessed, and the best fit for them is assigned. The other regulation basically says that rides are provided only to folks who have no other means of getting a ride. And of course, that has to do with, you know, fiscal responsibility and making sure that we have enough resources to meet the needs of everybody who really truly needs those rides. Not all of our Medicaid plans include transportation benefits. So many of our full benefit plans do, and those are listed here. So some members aren't, and essentially these are mostly limited benefit programs or partial benefit programs, such as senior care, which is a prescription drug program. It doesn't have an NEMT benefit in it. And then there's some things that, you know, like our nursing homes and members who are in family care partnership, or PACE, where the transportation responsibility is on the nursing home or on that family care or PACE HMO to provide to meet the transportation needs of their members and patients. We basically talk about three types of NEMT rides: routine rides, which can be, you know, to any kind of a routine appointment, a physical, a vision exam, something that you can predict out and schedule. Standing order rides are like if you have 12 physical therapy appointments after a surgery, instead of having to schedule each one individually, you can schedule those all at the same time for the duration of that therapy. Generally, these are approved for 3 months at a time. The exception would be with dialysis, which we can schedule out for 6 months at a time. And then urgent rides are those that are for a situation where it's not necessarily an emergency where you need to call 911, but you also can't wait 2 business days to see a healthcare provider. So this might be something like a discharge from a hospital, or if you go to a routine appointment and then there's a follow-up appointment that's scheduled within 2 days. And so you can schedule urgent rides. The different categories of NEMT are common carrier transportation. This is like a taxi, a bus, a sedan, or a minivan. Specialized medical vehicles are those that can accommodate wheelchairs or stretchers. We do approve ambulance transportation in cases where that is the most medically appropriate means of transportation. And then we also provide gas mileage reimbursement for those members who have a means of transportation but need assistance with gas money. And that mileage reimbursement is at 24 cents a mile. So now we're going to go over some of our key policies and processes. So to schedule a ride, members can call VAO's main number. We call it the booking number or the 800 number. There's also a TTY number to request that transportation. Rides can also be requested online. Rides for routine appointments must be scheduled at least 2 business days in advance. Rides for an urgent appointment would be provided in 3 hours or less. And I think, as we mentioned, rides for regularly scheduled appointments can be scheduled for up to 3 to 6 months at a time. And then if a member needs a return ride, they can call to get a will call trip or a return ride, and that will be available within 1 hour. So if a member asks for transportation by a vehicle other than a common carrier, like a specialized medical vehicle that could accommodate a stretcher or a wheelchair, VAO will accommodate the member's request for a period of time while they reach out to the member's healthcare provider to verify that need. After receiving the level of need or the LON attestation from the member's healthcare provider, VAO will determine the most appropriate mode of transportation based on that member's physical and cognitive conditions and assign that transportation and schedule that trip for them. Members may request a medically necessary attendant. An attendant is provided by the transportation provider to assist with things like wheelchairs and stretchers. And we'll talk a little bit more about this in a sec, but the medical necessity forms will be honored for 90 days until the existing ones that are already authorized through MTM will be honored for 90 days until January 31st, 2020, while we go through the transition. Just to note a couple of other policies around allowed escorts, meals and lodging, car seat requirements. None of these core things are changing. All these policies are the same. They can all be found in the Forward Health NEMT online handbook, and there's a direct link to that chapter at the end of the presentation. As mentioned earlier, federal regulations require us to provide the least costly mode of transportation that meets the member's medical and transportation needs. In general, a member may be required to ride the bus if they are within a half mile of the bus stop, or the bus stop is within a half a mile of their appointment, and if they don't fall under any of these exceptions. If they are unable to ride the bus because of physical or mental condition, if the member is a parent or caregiver traveling with a member age 4 or younger to their appointment, if the member is 15 years old or younger and traveling alone, or if the member is 70 or older and uses a walker, crutches, or a cane. There will be some service enhancements to this policy that we'll talk about a little bit later in the presentation, but this is sort of the core of it. And transportation for members under age 18 usually requires that a parent or caretaker travels with them, assumes responsibility for them for the duration of the trip at their appointments and upon returning. Some exceptions can be made to allow for a minor to ride alone if a parent or legal guardian signs a consent form. And I will actually just back up here and just note, with our minors traveling alone policy, I always like to just remind folks that if there is a change to the pickup or drop off location or to the timing or anything like that, you need to make those changes with VAO itself and not the transportation provider, because the information does not flow from the transportation provider up to VAO. It doesn't get into the member's permanent record that way. It might be sufficient for a one-off trip, but it won't be in their permanent record. So make those changes with VAO. That will flow to the transportation provider. It will be part of that member's permanent record, and they'll have the accurate information for future rides. All right. If a member receives poor service from a transportation provider, they can file a complaint with VAO. If a facility or other representative wishes to file a complaint on the member's behalf, they'll need to provide enough information so that VAO can identify the individual in the system and research the complaint a little bit more. So this would be things like the member's name, date of birth, or their Medicaid ID number. Complaints can be filed anytime, 24 hours a day, 7 days a week. And there's no limit on how soon after the incident that you must file. So even if it's weeks, months later, you can still file a complaint. And complaints can be made by phone, online, or by mail. Members can call the main line and select an option for filing a complaint. Complaint resolutions are reviewed by the VAO Quality Service Coordinator before they're finalized. If a complainant is not satisfied with the resolution of their complaint, they can notify VAO that they're not satisfied of the outcome and request escalation to the NEMT Ombudsman for resolution. If the complainant is still not satisfied with the resolution as provided by the VAO Ombuds, they can escalate it to the DHS Medicaid Transportation Advocate. This is a person who works for DHS and reviews all of the complaints. The member will receive a letter notifying them of the decision at each stage of this process. And the letters will describe the options if they're unsatisfied with the resolution and outline the next steps that they can take if they're unsatisfied. So now we'll talk a little bit about the transition to our new NEMT manager, VEO. The NEMT manager contract, and I should mention that the model that Wisconsin uses is our transportation manager is essentially a broker. They don't employ the transportation companies or the people who drive the vehicles. They contract with a network of individual transportation provider companies to ensure that there's adequate access across the state to meet our members' needs. So it's a small distinction, but it's an important one when you think about certain aspects of the program. So our NEMT manager contract runs on a 5-year procurement cycle. So we went through a competitive bidding process, and VEO successfully bid on the contract and was awarded that contract in April. Since that time, VEO has been working closely with MTM, our current manager, to ensure a smooth transition, to transfer all the information and files and approvals that are on file with MTM so that they get into VEO's system. And they will continue to work with VEO VEO will continue to work with MTM up until VEO's start date on November 1st of this year. And then also beyond if there's other things that need to be closed out or transitioned. So just trying to keep make the process as smooth as humanly possible. The other thing to note, and I know this is a hard slide to read because it's very small, but hopefully you can see it in the handouts that we sent out, is that we're doing all of our outreach right now in September and October, trying to make providers aware, both transportation providers and healthcare providers and other facilities that might arrange rides for their members, as well as getting the word out to our partners and to our members. And so that's all happening right now. And then the other thing to note is that any trips that are scheduled, closer to the end of October that will be taking place after November 1st will be scheduled through VEO. But up until that time, it's business as usual with MTM. And then November 1st is that go live date where VEO will begin making trips. So at this point, I'm going to hand it over to Adam Thomas, the Wisconsin Operations Manager for VEO, to talk a little bit about VEO and a little bit about some of the new service enhancements that they'll be implementing.
Sure. Yeah. First, thanks so much, Nick, and thank you everyone for giving us the opportunity to join the group today and share a little bit about VEO and share our excitement for taking over the NEMT services within the state of Wisconsin. So I just put a quick note in the chat box that I am seeing a few questions come in. Instead of trying to hustle and answer those questions in poorly fragmented sentences and misspelled words, I'm gonna let those accumulate a little bit and do my best to answer them after our portion of the meeting is done. And then if there's any that I just don't have the specific answer to, or I might need a little bit more information on, I will make note of that and work with Nick to make communication with the person answering the question. So I want to make sure that everybody knows that I intend to get back to those either today or as soon as humanly possible if there's a question that I want to do a little bit more research on. So first of all, who is VEO? VEO is, as you can see on the slide, the most powerful network for non-emergency medical transportation. We offer an extremely powerful network. It's a high quality, efficient fleet that integrates healthcare credentialed independent driver providers, which are what we call IDPs, along with traditional transportation providers to create a net new supply. So what that means is, if I just talk specifically about the state of Wisconsin, as we begin in the state of Wisconsin, we are starting off with a traditional 3PO transportation provider model. Essentially, we are contracting with organizations in many cases that are currently providing transportation, NEMT transportation services with MTM, excuse me. We're also sourcing for additional qualified and safe quality providers in that traditional model. As things get going, The other kind of augmented capacity type that VEO has successfully leveraged in other markets is to incorporate what we call IDPs, which are essentially independent contractors that operate in their own vehicle and leverage an app and our technology in order to work in a bit more ad hoc basis to provide rides. So we will slowly integrate that. We will be thoughtful and methodical as we do that. But in the meantime, we're trying to keep things as consistent as possible in this transition from MTM to VEO is possible. I mean, our end goal is to make this seamless for the members, seamless for the facilities that support the members, and obviously as seamless as possible for the team over at DHS. So I'll take that as a quick segue to loop back to one of the things that Nick said in an earlier slide, and that is when he was talking about, I forget the slide number, but how to contact NEMT. There's a telephone number that was shared along with the TTY 711 number. That number is the exact same. So the members that we have do not need to dial a new number. The number that they dialed for MTM is going to be the exact same number they dial for VEO. That should be a seamless transition. During this 60-day implementation or kind of carryover period of October and November, if there's any carryover that and a member needs to get a hold of MTM, but they got VEO, we will make sure that member gets to the right party. So just one example of how we're doing our absolute best to make things as seamless as possible. So what to expect on November 1st. And thank you, Nick, for jumping to that slide and proving that, yeah, it was already in there. So I apologize. Many things are going to remain the same. We are going to be researching and checking and determining eligibility in the exact same way per the guidelines from DHS. The booking number is the same. Transportation providers, the network in large part is going to be the same. We will still have a member ombuds here, and very excited to introduce her to the overall network of stakeholders here shortly. And the level of need process is not going to change. What are some of the things that are going to change or enhancements that we're going to provide? Our technology is really, and the platforms that we have is very user-friendly and creates a very valuable experience across all stakeholders in the process, from the members to the transportation providers to the facilities. It's really a wonderful user-friendly process, and that's going to drive a lot of the service enhancements that we have to offer. We have some excellent features within SMS capability, a critical care management team that is going to manage the care of those folks in that either dialysis or chemo treatment, just to name a few. Gas mileage reimbursement, when it comes to processing things, we have forms and ways to do that online. We have a third-party review entity. So essentially, as part of the complaint, or maybe you could call the adverse decision process, a member can request a review by a third party, which is an entity that is not a part of VEO, that has been contracted to review the decisions that are made, and that transfer and that review can be done at any point during the interaction with the member and VEO. We have a transportation provider ombuds, which is essentially an individual whose job is to act for and act on behalf of the transportation provider network that we are contracting with, to make sure that they have a voice within our organization, and that their needs and their concerns are being articulated within our organization. We view the transportation providers in our network as a partner. It doesn't mean we won't hold them accountable if mistakes are made, but we want to partner with them, and we want to have a growing relationship that is a net positive to the overall NEMT experience for the members and the facilities and other stakeholders. And then obviously, I skipped over one. The facility booking tool, which is called RideView, which is a platform that facilities can use to help facilitate transportation for the members that come in and get services. So for example, a person working at a facility can help book trips. If there is a standing order request, say it's for the same type of appointment every single week, but there's a closure of the facility over Christmas, Christmas week or something along those lines, the person at the facility can actually go in and cancel that ride on behalf of the the member. So lots of really neat functionality. with that ride view tool. Thank you, Nick. In Wisconsin, our presence here, it's large. So we're going to have over 100 Wisconsin-based staff. Madison office, we are right over the Beltline into Middleton. We have market operations, and then we have a call center. I'm about to introduce Bo Johnson, who is our director of the call center operations. And then we are also going to have an office and a presence in Milwaukee that is primarily market operations and supply related. However, those folks are going to be well versed in all different areas within VAO and the NEMT process within the state of Wisconsin, and can be used as a local resource if needed in the state of Wisconsin. And in the Milwaukee area specifically, that office is primarily geared towards working with providers and doing vehicle inspections and ability to be in close proximity to a number of the providers that we have. However, for escalating purposes, we can leverage that office as well. But the vast majority of our presence is going to be here in the Madison office. Thank you. Bo, I believe I'm going to turn it over to you. Is that correct?
Yes, that is. Thank you very much, Adam, and good afternoon, everybody. Again, much like Adam had mentioned, thank you very much for the opportunity to be here today with everybody. We truly appreciate the opportunity. And what I want to do first off here is just to kind of go through some of our forms, some of the information around forms. If you're not aware, during this transition between MTM and VAO, VAO has received several different forms from MTM, and we're implementing what we call a courtesy period to help try to minimize any type of member disruption when it comes to their services. Some of those forms that we've received are going to be the level of need form, distance verification, parental consent form, and again, we touched upon it earlier, but the attendant or the medically necessary form, escort medical necessity form. Now, with regards to members that do have current forms on file that were approved by MTM, again, those are going to be, they're going to be utilized and accepted up through January 31st of 2022. Again, courtesy transports are going to be provided to prevent any type of disruption. However, it is important to remember that prior to those forms expiring, we do need to receive new VAO forms prior to that expiration date. Now, and again, I kind of just touched upon this, but again, existing parental consent forms as well. Again, those are going to be accepted all the way through January 31st as well. But again, members would be required to submit new forms to VAO for those transports of February 1st onward. And in the event that for whatever reason, if MTM did have an active form on file, but it didn't make it our way, we didn't receive it here on the VAO side, the standard form submission guidelines would in fact still apply, but rest assured that process does still include a 2-week grace period for courtesy transports, by which those transports will be still provided until we receive that updated form back, again, to help try to prevent any type of disruption of service of any kind. Next, we're going to talk a little bit about some of our service enhancements. And first and foremost, we just want to touch upon real quick our RVR system, the interactive voice response system. And this is just your basic call flow tree. And essentially, when a caller does call into VAO, first they're going to receive an automated greeting. From there, it's going to ask who is actually making the phone call into VAO. Is it going to be the member? Is a facility calling on the member's behalf? And then from there, it's going to ask the reasoning behind that particular phone call. Some of those options are going to be schedule new transport, asking where's my ride, initiating a will call, or if it was a situation where the member did in fact have a return pickup scheduled ahead of time, just to notify that notify that they're ready for that return pickup. If there needs to be any type of change or an update to an existing trip, if they would like to cancel a trip, file a complaint, and then also if, and I'm sorry that it's quite small, if they wanted to speak directly to an agent. From there, it is going to go into kind of the validation portion of that IVR system, where there's going to be 3 pieces of information that the caller is going to have to validate for that particular member or who they're calling in regards to. They would need to provide the Ford Health ID, date of birth, and the first and last name of the member. Now, for some reason, if the caller that was making that phone call didn't have that information on hand, It would then ask for either the member's address, which it's important to remember that is the address that we do receive on the eligibility file. They would have to match verbatim, and the phone number. And again, that would be the phone number that is provided to VEO from the eligibility form. And again, it would have to match verbatim for it to make that automatic match. From there, the system will recognize whether or not that member or that caller has called in before and ask whether or not the member would like to opt in to our SMS text messaging, which we're going to touch upon here in a moment. And then from there, it's going to either go through directly to an agent or it will go through our automated system. Now, backing up just a little bit, if you noticed on the line there with all of the various options within the IVR system, you're going to notice a couple A's under some of those options. Any of those options that do have an A listed, that is that does signify that that particular option, the caller would be able to handle everything that they needed to handle via the IVR system without speaking to a direct agent. Now, with that being said, even if it was prompted and you're going through that automated system, you do still have the option to get through to an agent if you have additional questions, or if you would just prefer to speak to an agent, that is fine. But it is just noteworthy to point out that there are going to be automated options where, again, everything that needs to be handled would be handled through that automated platform. And from here, I'll pass it back to Adam.
Perfect. Thanks, Bo. And certainly, I think it's a pretty good segue. IVRs, we've all experienced them. We worked pretty tirelessly with DHS to get ours set up the way that we have it, and to try to make it as member friendly as possible. Another option that I get pretty excited about for communicating with VEO is in relation to, gotcha, getting a hurry up signal. Okay. I highly recommend everybody who is comfortable with it to opt into our text message service, our SMS text message service. A number of very handy notifications come by way of text message, and it also provides an excellent way to communicate directly with VEO via text. Some of these examples are here. After receiving a text, a member can click on a link and see exactly where their driver is in relation to where their home is, and get an understanding of how far their driver is away, their name, their vehicle. And there's also an option to rate the ride with the driver directly from that SMS. It's just super easy, prompted right at one's fingertips. Our member portal is not an app. It is a web-based portal that is specifically designed to be worked in any platform, whether phone, pad, or PC. And it's another way to communicate directly with VEO. A lot of those things that need to be done can be handled by way of this member portal or through a phone call, whatever means is preferred. Okay, perfect. Ride view. This is the facility ride view portal. This is what a facility would have visibility to, and many of the actions that the facility can make on behalf of the member, watching and tracking as how far out a member is, if for their scheduled appointment, scheduling will call and dispatch. They can help manage the trips on behalf of that individual in a recurring situation. All kinds of different things. It's very, very handy. Okay, GMR. The GMR is fairly straightforward. I think some of the enhancements that VEO can provide is the web-based online submission through the Wisconsin, our Wisconsin webpage. And then payments are primarily going to be made through EFT or through a physical check. Okay, the critical care team. Again, this is a team that is dedicated specifically towards those critical care members for things like dialysis, cancer treatment, hospital visits, and dental appointments. This team specifically creates a plan, monitors, and makes sure that the members that are parts of these programs have a higher level of visibility and planning, given the urgency and critical nature of the treatment that they're receiving. Lots of proactive quality assurance efforts. We have post-call surveys. Again, there's that critical care team. For trip quality, we have a secret rider and unannounced vehicle inspections that we are doing routinely and report back to DHS on a cadenced, very specific basis. Drivers, people who opt into the SMS can easily do a driver survey. And then there's also ride tracking. So we are using digital tracking to track the providers in our network to improve transparency for all, and take some of the guesswork out of, was a person late, was a person not late? We're going to be able to track that all and be able to share that. Okay, complaints escalation process. Nick covered some of this, but at any expression of dissatisfaction by a member, we're going to ask them if they would like to file a complaint. Submissions go right into our Salesforce platform. Our Salesforce platform is a shared platform that members of DHS have real-time visibility to all the different complaints that are happening. We have a QA team that's going to be based here in Madison with a very robust process that investigates all complaints and does a deep dive into each situation and gathers all requisite information so that we can resolve that complaint and understand it better, but also gather information so that we can make decisions using data about chronic issues, whether it's a certain provider, a certain agent at VAO, or something else, so that we can take action.
All right. Well, thank you, Adam. And thank you, everybody, for bearing with us. We know it's a lot of information, kind of a long presentation. Saving the best for last year, you know, the service enhancements, and now talking through some of the policy enhancements that I think you guys will find interesting. So we already talked about the third-party advocate review process for any sort of adverse decision, but essentially the third-party advocate has the ability to either uphold the decision of VAO when they called into the call center, or to overturn it. And so it's an addition to the existing grievance process that you're all familiar with. In our previous experience, we've realized that misrides can occur when there's a change in the transportation provider on short notice, especially within 24 hours. And so to prevent that from happening, to prevent people from missing the fact that they've got a new transportation provider assigned to them, or not recognizing the vehicle, VAO will basically lock in the scheduled transportation provider within 24 hours of the ride, unless there's some, it's an issue of safety or something like that. Oops. And then we talked about the bus rides earlier here. And so there are a couple of additional exemptions that we're going to put into effect under the new contract. So in addition to the age and physical and mental limitations, and distance to the bus stop exemptions for being assigned bus rides, under the new contract, you won't be required to use public transportation if it would result in drop off at the appointment more than 90 minutes before the scheduled appointment time. If there is less than 45 minutes between the end of the appointment time and when the pickup is, so allowing folks to have adequate time to get to their pickup point. If the trip requires more than 3 transfers, or if the total travel time, including waits between transfers, is more than 45 minutes longer than what the average travel time would be if they were directly transported by common carrier or some other means. So we think that these changes are going to make it, the public transportation option, much more palatable for folks. It won't be, hopefully we won't get into situations where folks have lots of waits and lots of transfers and all of that. This is an exciting change. We've definitely heard the feedback and interest in, changing our additional riders policy. And we had to be very thoughtful with how we approached this, because we needed to be in compliance with federal regulations to do this. So, but we do have a enhanced additional riders policy now. So additional riders can be accommodated if they're requested by the healthcare facility, if they're under the care of the member, or if they're a dependent of the member, or if they're acting as a support person. And so the member or whoever is scheduling this on the member's behalf, the ride on the member's behalf would request this accommodation to have an additional rider or two come along on the trip at the time that it's being scheduled. the key to this is that the number of seats, the number of allowed additional riders that can join the member on a ride has to be accommodated by the most efficient and medically necessary mode of transportation that the member is provided. So for example, if mom has got 2 kids and she has a ride to an appointment just for herself, not for the kids, and that sedan has got 2 extra seats in it, if they can be safely and legally transported in that mode of transportation, they can join her on that ride. However, mom can't request to get upgraded to a sedan because she's got her 2 kids and like some cousins or whatever it happens to be. So the basis for the type of transportation that you get is still based on your medical and transportation needs. But if you can safely and legally transport additional riders, that will be accommodated under the new contract. So it's not perfect, but it's an exciting new addition that we're happy that we were able to figure out and offer to folks. And then just to mention that we've got some additional transportation provider network requirements to improve the number of specialized medical vehicles that are available to folks, and some new quality assurance oversight that will be measuring, time to pick up for will call and urgent request rides. And as Adam mentioned, we have a new transportation provider ombudsman to help mediate and focus on those transportation provider issues. I'll just share this slide real quick. Additional resources. This is literally everything we've got on our NEMT policies. The policies in the Forward Health Provider Handbook and on our website will be updated as of November 1st. You can sign up for email alerts at that top link. There's existing fact sheets and stuff. This NEMT webpage will be built out and it'll go live closer to November 1st with the new service enhancements and policies and things like that. And then this link down here, I hope you guys can see my little pointer where the mouse is going over, but the Forward Health Partners, Community Partners webpage has an archive of member updates that have gone out previously, and that includes updates on this benefit. So, and then lastly, here are some links to the new VEO websites, which will be going live closer to, I think closer to November 1st. Adam can correct me if I'm wrong there. And then if there's any other questions that occur to you or comments or feedback that you want to provide, this Forward Health Partners email address is where you can send those questions and comments. They will go to myself and Maciel Gomez, who I think many of you know. We monitor that inbox and we will work with our policy staff and program staff to get answers and to provide that feedback and input up to folks. So with that, sorry for taking so much time, but hope that was informative to folks, and we'll open it up to questions.
Actually, we don't have any time for questions at this point, so we will collate the questions, and if you'd be so kind to answer them after the meeting, that'd be great.
Absolutely, happy to do that. And if there's any questions that are already in the chat, we can answer those now before we sign off as well.
Okay, Mary.
All right. I'd like to welcome the Hub and Spoke program from the Wisconsin Community Services as a follow-up to our forum. It is especially timely to hear from WCS about a new treatment model, the Hub and Spoke program. You can also find more information on the website, meeting posts, and I'd like to welcome Eric Diamond and Maya Robinson. So take it away, guys. Ladies.
Hi, everybody. Just wanted to check in. This is Eric Diamond. I just wanted to check in. Can you see the presentation in front of you?
Yes, Eric.
Okay, thank you so much. So thank you, Barbara. Thank you, Mary, and other members of the Mental Health Task Force. We're really excited to be here. We're here to talk to you about the Hub and Spoke Health Home. Really, I'm going to hand off to Maya Robinson, who's our leader of the program. But before I do, I just wanted to share really briefly about WCS. Wisconsin Community Services, many of you know, is a major nonprofit in was in Milwaukee. We have over 100 years of service to the community. We do a lot of different things. We provide mental health, substance use, restorative justice, and housing services to adults, youth, and families. We're quite large, and we're getting larger. We're always looking for new ways that we can serve the community. We have over 16,000 individuals that we serve every year across 40 unique programs. We employ 450 employees, and we have a growing budget of 44 million. One of the highlights I just wanted to share about WCS is that, and I have never worked in an agency that does this and does this so well, is that WCS employs over 50 certified peers in a variety of different roles. We have peers who are care coordinators. We have peers who are in the traditional role of certified peers. We have peers that are supervisors. And very appropriate to the discussion about Hub and Spoke, which employs a great number of peers and uses peers effectively in its service delivery. So just a couple of thoughts here from me on WCS, and I really want to hand off to Maya Robinson, who's our leader for the Hub and Spoke program. So Maya, please take it away.
All right, thank you so much, Eric. I hope you all can hear me. Can you all hear me okay?
Yes, Maya.
Great. Okay, perfect. We always have to double check these medias to make sure they're working. Some days they do, sometimes they don't. So I'm happy that it's working. So like Eric said, I'm Maya Robinson. I am the director for Hub and Spoke here at WCS. It's so exciting to be here. Thanks for having us. So I'm going to just go through a few of these slides and kind of explain what Hub and Spoke is, what we've seen so far, and the experience we've had with it so far. So this is some of our vision bullet points here. The whole goal of Hub and Spoke is to just improve communication across providers, across programs that are in our county, and just overall making access available for people who are in recovery. I think it's a much needed service. There's also a lot of other programs in Milwaukee that have similar services, but this one is very unique. And we will talk about how it's different from other services and how we are just trying to partner with everybody to make this work for the people who are seeking these particular services. So yeah, these are just some of the bullet points. The sustained engagement is really, really key to this one. While people are in recovery, we want to set them up for long-term beyond Hub and Spoke, making sure that they can claim a space in the recovery world and become what they always wanted to become, a better version of themselves. So that's kind of what we're going to be touching on today. So I'll just go through the slides. Go ahead, Eric. So right now, the Hub and Spoke Health Home, what we're doing now as far as our region and the people that we're servicing is throughout Milwaukee County. It is a state-funded program. It's Medicaid. As long as people have eligibility for Medicaid and they want to work on recovery, they're eligible right now. Right now it is a pilot, and we hope that we can bring some really good outcomes to make it a entitlement for everyone who wants the service. So right now we're servicing people who are 18 years and older. They have to align with one primary substance use disorder and also co-occurring mental health or physical health needs. So we're seeing a variety of people in this population, but we do really focus on that primary substance use disorder. And that's our target population. Right now, what we've identified as our barriers is the rapid access. A lot of times people who want services are put on wait lists, or they're just not going right to get the services. They've been driven down a different path. It takes several days or several appointments to actually get the services. So what we did was we kind of explored different ways that people were getting hung up in these systems and just trying to help them figure out what will work best for them. And we just learned that rapid access is key to this type of service for it to have a longer term outcome. So we want to make sure that we're always present with people when they want recovery right away. So what we're doing is we're making ourselves available. with our spokes. Our spokes are the different providers in the county who work with people in treatment, and we're like the supplement. So basically, if you are a MAP provider, or if you are a behavioral health provider, or even a provider for medical care, and you would like to refer a person or partner with us and refer a person that you're working with for the hub and spoke service, we're like a supplement. So we can help people outside of the treatment setting. And thus that'll kind of keep them engaged in treatment much longer. So it's kind of like a holistic approach in partnering together. So it's pretty much bridging that gap across the health systems. It's very, very exciting so far, learning about all these different systems, all the different needs of all the different providers. And we're just taking all of that in, and we're trying to just work through it as best as we can. I think it's going great so far. It is a lot of information, a lot of different systems. And to just let our folks know that we're out there to go through this with them and that they're not alone. So again, rapid access is our biggest goal here. When someone wants to have this type of service, we make sure that they are connected right away. We try to make sure we're connecting, if not in 24 hours at the most. But usually we can go out right away if we get referrals earlier enough. If it's a situation where someone really needs to connect with one of our peers, we try and make sure they can at least get a phone call right away and just kind of catch them in that window of hope and making sure they have rapid access. Another good part of the rapid access that I wanted to touch on is when they're dealing with the providers or our spokes, we are making sure that our partnerships are with people who work in these different health programs that we know we can get them through. So for instance, if we wanted to know if there were spaces available for partial hospitalization or intensive outpatient or any type of inpatient treatment, or even if it's just peer support, whatever they might need, we are making those partnerships, relationships, and connections with people that we know will be able to help that person on the long run so they don't have to do it themselves. Kind of like what Eric was saying, our interests, definitely our peer supports and our specialists, they are the people that drive this program. We would not be able to do it without them. This is why we got involved. Peer focus modeling has helped people in recovery. It's empirical. We have all the evidence and everything that we need to know that this is a service that will work as long as it's driven by the peers. So we recognize that benefit of that rapid access, the genuine connection, and that's what makes it unique. We can send our peers out right away and they can connect with people right away. And I think it makes people feel at ease, and it makes them feel really good that they have someone who has been in their shoes that can really relate to them in that moment where they want that help. They can share that lived experience, and they can really engage people to continue and give them a reason or a purpose, even if they don't have one in the moment, to just stick with it and hopefully remain in recovery longer than they may have before. And like Eric said, we have, I don't know, how many peers do we have, Eric? I think over 50 or 30?
Yeah, 50, a little over 50. Yep.
We have over 50, and it's an honor to work with these people. They bring so much knowledge, they bring so much experience, and they just know so much about everything that's going on in our community. Whatever we need to find out as far as sober living, different meetings, they're connecting with health departments. They're doing all this stuff that we need them to do to help us move this program and forward recovery for people. So that's what makes it really, really unique. The unique features about our region, we kind of talked about this, about our population right now. These are some of the features. We know the opiate crisis and the deaths, that the pandemic has made it worse. As far as the high poverty, all of the social determinants of health, the child poverty rate, of course. We really wanted to focus on this housing crisis, though. A lot of people that we're seeing that are coming into the hub service, they're having a lot of different crises going around them, mostly on housing. We know housing has always been a big issue in our community. So we wanted to make sure we do focus on this as much as possible, and that we're very sensitive to what people are going through. The picture to the left is just something that we collected during the pandemic. It was a real eviction notice that someone got. And I just like to share this sometimes because we pay attention to stuff like this. This is very traumatic. There's nothing happy or friendly about being evicted, especially during a pandemic. And so if someone were to get this eviction notice and they're going through, you know, addiction or they're trying to get help, you know, we are sensitive to this. And we know that right now our community is not trauma informed. And maybe it wasn't intentional, but it does affect everybody differently. So we're very sensitive. We pay attention to what people are triggered by. And we kind of always try to think trauma informed. What's happening to you, not what's wrong with you. What are some solutions instead of focusing on problems all the time. So we're training our teams to do that. We all take this type of approach. And I think that's kind of why we have some success and what makes us a little bit more unique with this. So the service types in our substance use disorder provider integration, it's vested in mobile connections. So right now we do have an office located in Milwaukee. We're off of 27th and North Avenue, but we also have access to be mobile as much as possible. So if you have maybe someone who's going to be getting discharged out of an inpatient facility, we can go and meet that person and start discharge, engaging and planning right away. If someone wants to get into services, you know, we also have that ability too, where we can meet that person right where they are in the community, in the time of need, right when they say they want that help, we can be there. So we've made ourselves very mobile, very community oriented and focused. We do foster a two-way referral process across health systems. So although we are accepting referrals from all the providers that we're connected with, we are also asking how we can help the providers, you know, how can we get people to you and vice versa. So we do foster that definitely with all of our partners. And then these are just some of the services here at the bottom: inpatient, residential, partial, any type of level of care. We can engage at any type of level of care. Some people just want to talk to somebody that's, you know, been in their shoes before. Some people just want to get in, fix a couple of things in their lives and get out. We are flexible with whatever they want to do, and they can drive their own recovery. So we'll talk more about spokes. A lot of times when people hear about hub and spoke, they're like, what's hub and spoke? The spoke portion of it is, like I said, these partnerships that we're developing with all the different programmings across the county, health systems, community agencies. Some of our spokes are very small, some of them are large. It all depends on who wants to partner with us to help add this wonderful service to their treatment process. So these are a few that we've partnered with so far. The list is actually much longer as we continue to build relationships as we move this program forward. So I'm pretty sure you all are kind of familiar with these that are on the list now. And we've got some really, really good relationships with some other providers that aren't on this list. So we've had some good responses so far. Basically, what we try to do is while we're meeting people where they are who are in recovery, we're meeting spokes where they are too. So sometimes if one of our spokes wants us to be on site with them because they have people coming in and they want to engage people right at the moment of initiating treatment, we can be available right there. They don't have to wait for an appointment. They can probably schedule something right away. They can see their treatment provider, and then they can see us on site as well and get everything started at the same time. I think that's a very good benefit of this program that we can do. And I think some of our spokes really appreciate that, instead of having to fax a referral or call a referral line or set up an appointment. You know, we're embedding ourselves into these different systems so that we can be available and capture people right when they want that help. So these are some of our goals in the next 6 months. The capacity we want to be at is about 60. I think we're already there now. I'm sorry. We're already with 60 people. We want to get to 120 by the end of the year. We have referrals coming in, and we're just trying to work on different strategies to keep people engaged as long as possible, trying to help them knock down all those barriers. We want to reach 180 by March, and then the capacity of the current budget and plan would be about 250 people. So we have openings. Like I said, right now we have 60 people enrolled. We've been doing enrollment since July. So we'll continue to grow and we'll continue to accept people. If people are not Medicaid eligible, we're not denying or turning them away. We're making sure that that they may be eligible for Medicaid. We can run applications. We can kind of look at their income. And if not, we can also help them get referred to programs that aren't Medicaid only. So just because they don't have Medicaid doesn't mean they're not eligible, or that doesn't mean that there's not a program out there that could work with them. So this is how you refer to Hub and Spoke. You can use our referral line. It's all electronic. This is the link that you could use to get to that referral. We also have a release of information that you all could send to our Health Home Info email group. We have some flyers out there too. I believe we gave Mary some before with little QR codes on there where people can scan with their phones and they can do self-referrals, which is the best type of referral when people just refer themselves because they're probably super ready at that moment. So there's different channels that we can receive referrals. We also have a referral line as well that's on the website.
Maya, there was a question in the chat. We don't have a lot of time for questions, but what is the difference between your role and the role of a care coordinator?
Oh, okay. So yeah, I'm sorry if I skipped over. I talk about Hub and Spoke so much. I probably forgot to mention that there is a team approach with this program. So they don't just get a care coordinator, they get a care coordinator and 1 to 2 peers on their team to help them in recovery. So the role of the care coordinator is to direct the care and to just make sure it's a traditional case management type of role, making sure services are set up, making sure all of the social domains are addressed. And then the peer support actually helps implement most of these things with the person. They can go to meetings with their peer. The peers can help them just kind of get started on their journey, coming up with some goals. You know, maybe the person wants to start working out or addressing their diet or nutrition, whatever the case might be, the peer can do it with them. So they get a team, not just one person to work with.
All right. Thank you so much for Maya and Eric for joining us today. We've got to move on. We've had a very dense and full agenda, and we'll have you back sometime. Thank you so much.
Thank you, Mary. You all take care. Thanks for having us.
Okay, bye.
Thank you so much.
Christine?
Okay, Sue, are you here to, we're gonna do forum wrap up with Sue Gaddich.
Yep. Yes, I am here. That's okay. It's a hard last name to pronounce. That's fine. Yep. I have just a little bit of additional information I wanted to share with everyone. First, if you are someone that participated in the forum last month, it was on September 15th. Thank you. Thank you very much. Our forum was in honor of Karen Avery. The topic this time was celebrating recovery, ending stigma, and embracing possibilities. Our intent during this forum, was to identify opportunities to address substance use disorders as a public health concern. And we did feature some international keynote speakers that normalized harm reduction strategies and addressed the many pathways of recovery. We had 116 participants, and overall, the evaluation results were very positive. I think a few of the highlights from the forum itself was the community expert panel that featured the voices of individuals in recovery and service providers. Those experts also led our breakout discussion that offered incredibly valuable feedback on the current and future service direction for consideration for the treatment of substance use disorders in the Milwaukee community. Our speakers and our breakout groups were united in identifying some of the key success factors to supporting recovery as offering a broad continuum of services, including access to housing, encouraging voluntary treatment, treating individuals with dignity and respect, having recovery coaches and peer specialists as a resource, and having a workforce that reflects Milwaukee's diversity and supports clients in a linguistically and culturally appropriate manner. It was critical that we place culture first. We always want to, identify what's working here in Milwaukee, and probably the one common theme that was shared across all of the breakout sessions were the peer respite and having that level of care provided by peers. Also, another effective strategy is the availability of the Narcan Direct program and the use of recovery support services, including peer recovery coaches. It seemed that there were also some common themes in what is actually needed here in Milwaukee County. One is a needs-based naloxone distribution. And the definition of needs-based is really to react and to respond where the highest percentage and number of overdose, both fatal and non-fatal, are occurring in the community, and to channel and direct resources specifically to those areas. Another thing that I'll speak a little bit more in depth on is to really begin to look at the need to amend the state law in Wisconsin to remove fentanyl test strips as illegal drug paraphernalia. And last but definitely not least is just the need for affordable housing. People need to have safe places to recover. I wanted to share with you also what the Mental Health Task Force has done, the steering committee has done since the Care in Avery Forum. So on September 23rd, we submitted testimony to the Mental Health Board that identified the significant rise in overdose deaths in both 2020 and also in 2021. 2020 was a horrendous year for fatal drug overdose deaths across the country, and specifically here in the state of Wisconsin and in Milwaukee. We lost over 450 individuals to opioid overdoses, a higher number of individuals to just general drug overdoses. And sadly, we are on pace in 2021 to exceed that number. During that testimony to the Mental Health Board, we did ask the Mental Health Board to act on the items that I talked about as to what's needed, which is needs-based naloxone distribution to support, removing fentanyl test strips as drug paraphernalia, and more availability of affordable housing. The steering committee recently requested to place an action item on the Mental Health Board's October 28th agenda to support Senate Bill 600. And Senate Bill 600, and I don't know if you were at the forum, if you were following the chat box, but Senator Lena Taylor was participating in the forum. And one of the things that she shared was legislation that she introduced to look at removing fentanyl test strips as illegal drug paraphernalia. That now has gotten a Senate bill number, and it is Senate Bill 600. And one of the things that Senate Bill 600 does is it adds fentanyl test strips to the definition list of drug paraphernalia exclusions. So it excludes fentanyl test strips. We see fentanyl test strips as something that is a critical life-saving resource. Just a couple of the things to keep in mind is that when people who use drugs have access to fentanyl test strips, it has shown a change in their behavior, a change in drug behavior, whether it is using less, not using with individuals who may have naloxone. And I think one of the things that's critical about the importance of having access to fentanyl test strips is it saves lives. When we were talking about the drug overdose deaths in 2020 and in 2021, the drug overdose deaths in 2020, 60% of them included those drugs were synthetic opioids, which is what fentanyl is. In 2021, to date, the number of drug overdose deaths where fentanyl was included is close to 75% now. So we're seeing that, continuing to, to tick upward. The street supply is inconsistent and unpredictable, and the lethality of fentanyl is something that is just significant. So that is the main reason why we asked as the steering committee to add that action item to the Mental Health Board's agenda, that they support Senate Bill 600 that adds fentanyl test strips to the definition list of drug paraphernalia exclusions. I think if the majority of the board supports this action item, the Mental Health Board would have to request that the County Executive Office join in the legislative support of Senate Bill 600. We have an ask. The Mental Health Task Force Board or Steering Committee has an ask, and that is to please contact your state legislators and ask them to support Senate Bill 600. If your legislator is a sponsor, and the Milwaukee senators that are sponsors are Lena Taylor, Chris Larson, and Tim Carpenter, or co-sponsors who are our representatives, Sylvia Ortiz Velez, Dora Drake, Christine Sinecki, David Bowen, Daniel Canodal, and I'm mispronouncing his last name, I'm sorry, and Maricel Cabrera, please reach out to thank them. Thank them for their support and their sponsorship and co-sponsorship of this legislation. I almost wanted to put a message in the chat box for both VEO that their drivers have Narcan, as they're transporting individuals, and that the WCS hub and spoke, the peers that are working also have Narcan. It's at a crisis. One of the things that we said during the testimony is the house is on fire. We cannot lose another life to opioid overdoses. And so if there are any questions, I can answer questions related to the ask that the task force steering committee made, or if not, then I just would ask that you also please consider your support of Senate Bill 600. And I thank you for your time. That's it.
Thank you very much, Susan. Any questions? Okay, well then we do have time. We were going to not have time, but we do have time for Mary Neubauer. Thank you again, Susan. It was a great
Hello. Okay. So, policy updates, the Mental Health Board and state legislation. The Mental Health Board will be meeting on the October 28th, and on the agenda, it says that the meeting is at 8 a.m. The finance meeting is actually at 8 a.m. and the Mental Health Board proper meets at 9 a.m. But please come to the finance meeting because then you'll be prepared for the board meeting at 9. So that's all included in the packet for today's meeting. Legislation that's going on. We talked a lot about peer specialists today and recovery coaches. And there was legislation that was included in the budget last year, or in the budget, which was Act 122, that I will be reporting on, and I'm not prepared to report on it today. And what it's about is recovery coaches were included in the budget this last year, and now they're hammering out through the Department of Health Services the role of recovery coaches and supervision and how it's going to be covered under Medicaid, and it's going to be different than peer specialists. And so there's going to be some meetings as to how they're going to try to work this all out. And I haven't even mentioned this to the committee, but so this is all happening because the way that the legislators putting the language in has to be hammered out differently than it was written. And it's so important to have recovery coaches who are people with lived experience of substance use included as our peer specialists. So that's just a little legislative update. And Barbara, anything that you wanted to mention as to legislation or anything relative?
Thanks, Mary. I just would like to thank everyone for taking in a lot of information today. And we hope that one of the things that'll you really take home is the need for action. Sue spoke so eloquently about the crisis in our community right now and the people whose lives are on the line. And this bill, SB 600, that would make some positive changes and seems to have bipartisan support, really may have some momentum. So we tried to lay out the details for you in our action alert. We hope that you will consider taking action and advocating for this. And if there are any questions or comments, I see that there are a few questions in the chat. You know, we do have a few minutes left and could address those. We're at the end of the legislative session and really felt like there's some good momentum coming out of our forum. So asking all of you to help move that forum and to make a difference with all the suffering that's going on in our community right now. And this is one relatively easy thing that we can do. Email your state senator and your assembly representative and ask them to support this bill. And, you know, who knows? Oh, I see a question there about reaching out. Yeah, so I can just bring up the action alert again, just to kind of help walk people through that process. So it's on our website and I'm just gonna share my screen once again to show it to people.
My life was severely impacted. Oh, sorry, Barbara.
No, that's okay, Mary. If you wanted to share something, please do.
Yeah, my friend Tim was one of the statistics from 2020, and he was impacted both by the Narcan and fentanyl. On a Friday, he was administered Narcan and survived an opiate overdose. And then on Saturday evening, he went to use again and thought he bought heroin, and his autopsy showed that he had injected with 100% fentanyl. And it's been a painful loss for me. So I truly hope that this bill passes. And I know others whose lives have been impacted by this terrible fentanyl thing. And it's just horrible. I lost my best sports buddy, and it's rough. It's really rough.
Oh, well, thank you so much for sharing that, Mary. And that really speaks to the loss that so many families in our communities are dealing with. So in terms of the process, the action alert's on our website and it kind of lays it out for you. All you need to do is first, if you don't know who your state senator and legislator are, we've provided the link here for you to look them up. You just go to the state legislator website, enter your home address in the who are my legislators field, and it will give you the phone number and the email address. So whatever you're most comfortable with. Sometimes people don't want to talk to someone, so you can call in the evening and leave a message. Voicemail's on all the time. So all you have to do is leave a message, you know, let them know you're a constituent. That's really important. And give your address and ask them to support Senate Bill 600 and just say a line or two about why it's important to you. And if you want to say more, you can do that too. So phone or email whichever is easiest for you, and be sure and get your name and home address in there because legislators want to hear from people who live in their districts. So I think we really can make a difference on this one. So encourage you to take action. And we do have a list of the sponsors. And as Sue said, if your legislator is already a sponsor, it's still great for them to hear from you with a thank you. It's important to say thank you when they do something that we support because that doesn't happen often enough.
And just
I'll turn it back over to you, Mary and Christine, to wrap up for us.
Okay, just in mentioning our November 9th meeting will be dedicated to our veterans. We have, in honor of Veterans Day, we'll hear from Brian Michael, and Brian is the Director of Prevention Services for Mental Health America, and Sarah Kolbeck is the Director of the Division of Suicide Prevention from the Medical College of Wisconsin, and they'll be talking about the Remembering the Lost project. And this is a major project that's going on. And it's actually a project that I consult on with Mental Health America. And it's a project that is focused on looking at death by suicide for veterans. And it involves peer specialists being able to speak with the significant others and families of the veterans that have died by suicide to get all kinds of information. And so Brian and Sarah will be providing a lot of detail and a lot of information about that project and some breakthrough that they've been able to get with the government to get data to really build a significant capacity of a database. And then also we'll have an update on the Mental Health Emergency Center with Jessica Small from the Advocate Aurora Behavioral Health Center operations, and Mike Lappin from the Milwaukee County, the administrator from the Milwaukee County Behavioral Health Division. And again, please check out the agenda for the Mental Health Board meeting and tune in so we can watch and have a historic moment and hope that the Mental Health Board supports the bill 600 to get these fentanyl strips removed from the paraphernalia list for the state of Wisconsin. So Christine, anything for you?
Nothing, just a reminder, October 28th, there's a Mental Health Board meeting at 8 a.m. and Shirley and Mary will be there. Mary will be there, hopefully.
So again, thank you to all of our presenters and thank you for being here, and we will see you next month.
Good night, everyone.
Take care.
Bye all. Thank you.
Have a good evening, everyone.
Well, it sounded like Nick said that he got to the different questions for the NEMT.
Good.
Yeah, it's such a big topic.
Yes, it's a huge topic.
Yeah. Yeah, a lot of good information. All right, Mary, you take care.
Yep.
Your eye's doing okay?
Yeah, eye's doing good.
Excellent.
All right.
Talk to you soon.
Will do. Bye-bye.